This is Matthew Shetterly of Essex, Maryland. He's 5 years old in this picture. It would have been taken in 1995 or 1996. I love the pants that he's wearing. You can see Charlie Brown and Snoopy there in the pants pocket. These are Matthew's parents, Michael and Barbara Shetterly. This picture was taken right before Christmas in 2018, and Matthew wasn't there. As he'd gotten older, Matthew had gotten addicted to opiates, and one spring day in 2014, the Shetterleys came home to find Matthew slumped over with a needle still in his arm, unresponsive, in his childhood bedroom. They gave CPR and called 911, and he was rushed to the nearest hospital, and all the right things were done. But it became apparent over the days that followed that Matthew was not going to recover. He was brain dead. But Matthew was an organ donor, and so after his parents held his hand and said goodbye, surgeons came and removed his heart and lungs and kidneys and took them to other hospitals where other people got those organs. And the Shetterleys always wondered about those other people. They wondered what good might have come to their lives because of the tragedy that had befallen theirs. But it took them 2 years to feel ready to reach out to those families. And then when they did, the Living Legacy Foundation set up a meeting between the Shetterleys and the man who had received Matthew's heart. This is Irv Basden from Fairfax, Virginia. He's a husband, a father, a former college football player, a professional accountant. Several years before, he thought that his life was about to be over. He had a cardiomyopathy, and his cardiologist explained to him that a transplant was his only chance to survive even a few more years. They listed him for transplant, and one day he got a call that a heart was available. Matthew's heart. Irv and the Shetterleys met on July 16, 2017, which would have been Matthew's 27th birthday. And when they met, the Shetterleys listened with a stethoscope to their son's heart beating in Irv's chest. This is transplantation medicine. And over the course of this lecture, we'll review the history that makes amazing stories like this possible. We'll review the medical and surgical aspects of managing transplant patients. We'll consider some of the policies that underlie organ allocation, and we'll dream about what the future might hold. By necessity, we're going to need to move pretty quickly, and our handling of some of these topics is going to be pretty superficial. But my hope is that this lecture will inspire some curiosity and maybe a desire to learn more or potentially even contribute to the care of these patients in your own professional careers. Part 1, History. This picture is from a CBS News conference in the 1960s as three of the most famous heart surgeons in the world at the time, Christian Barnard, Michael DeBakey, and Adrian Kantrowitz, are holding this heart model and discussing the possibilities of transplanting a human heart, which really still ranks as one of the mountaintop achievements in all of medical history. It's got to be right up there with the discovery of penicillin or the smallpox vaccine or the discovery of anesthesia. But what sets transplantation apart is that the ideas of some of the technologies that we use in medicine today would be completely beyond the understanding of people who came before us hundreds or thousands of years ago, but not transplantation. In fact, many world cultures have some mythology about transplantation built into their culture. The idea that an organ could wear out and you just get a new one is something that has fascinated human beings for millennia, but it was always out of our reach. For a long time, the biggest barriers were surgical. But by the time that we got to the late 1800s, early 1900s, surgeons had the skill, in theory, to conduct an organ transplant, and many surgeons began to think about doing that very thing. One of the early pioneers in the area was Yuri Volinoy. He was a surgeon in the Ukraine, and he had done some experimentation with animals and perfected some of the surgical anastomoses and began to think that this was something that could be done in a real human patient. And then, in 1933, he got his chance. From his own account, a 26-year-old female patient, married, was admitted to the hospital on March 3rd, 1933, after the poisoning with mercury chloride with suicidal intention the previous day. Unfortunately, inorganic mercury is a potent nephrotoxin. It gets taken up by the proximal tubule and causes necrosis. And this being the pre-dialysis era, this patient's fate was certain. She was going to die, unless, of course, Dr. Voronoi could give her a transplant. So we made the decision to perform the kidney transplant, and at this time, a 60-year-old male patient with a basal skull fracture who had come from a local rock quarry was admitted to the hospital. Soon thereafter, he died, and seeing no other option to help his patient, Dr. Voronoi went to the operating room and tried to transplant the kidney into his 26-year-old patient. Interestingly, directly after the release of the blood circulation, a peristalsis of the ureter and the outflow of a few drops of urine could be reserved. The transplant worked. But then, despite the proper pulsation of the renal artery, the little production of urine stopped at the end of the operation. Dr. Voronoi didn't understand what had happened. Everything was hooked up the right way. It wasn't clear why the kidney didn't work. And of course, the reasons why it didn't work were beyond what he could have understood at the time. As it turns out, the donor and the recipient had different ABO blood types, and what he just observed was hyperacute rejection. It soon became apparent through Dr. Voronoi work and the work of many others that the major barrier to successful transplantation was not going to be the surgical technique. It was going to be our ability to understand and manage the immune response. Fortunately, in the years thereafter, scientists would begin to unravel some of the mysteries of the immune system that would ultimately make transplantation possible. This is a seminal paper from Peter Medawar that appeared in Nature in 1953. It's a paper that you probably have learned about in your high school or college biology class. It was known that our immune system had the ability to recognize foreign tissue. If you took a skin graft from an animal and put it on another animal, the graft would be rejected. But interestingly, Medawar observed that mammals and birds never develop, or develop only to a limited degree, the power to react immunologically against foreign homologous tissue cells to which they have been exposed sufficiently in early fetal life. Here's the experiment right here. If you took a skin graft from this gray mouse and gave it to the white mouse, or from this Rhode Island red rooster and gave it to the white rooster, and you did it early in life, the graft took. The immune system accepted it. It did not recognize it as being foreign. And further work further defined how our bodies define self from non-self and led to the discovery of medications like corticosteroids that might suppress some of those responses. Meanwhile, surgeons continued to work on the technique and concepts of transplantation. Pictured here is Dr. Joseph Murray from Boston. He is the surgeon who conducted the first successful kidney transplant, and the gentlemen pictured beside him were his patients, Richard and Ronald Herrick. You'll notice they're identical twins. Richard had developed IgA nephritis, and by the time this was discovered, he was given only a few months to live. But the brothers had heard about Dr. Murray and his work in Boston, and they paid him a visit. And so you can see in this consultation, Dr. Murray is showing Richard and Ronald an early dialysis machine. This will be familiar to you if you've watched the AKI lecture. Of course, when he met the Herricks, Dr. Murray saw the opportunity to overcome the barrier that had plagued previous attempts at transplantation. After all, they were identical twins. He wouldn't have to worry about rejection. Just to be sure, Dr. Murray did a skin graft from Ronald to Richard, and it worked. And thus, on December 23, 1954, Ronald donated a kidney to Richard, and it worked. Richard went on to live for another 8 years before he died in a motor vehicle accident with normal graft function. Of course, not many of us are lucky enough to have an identical twin to serve as a living donor. So for most patients with chronic kidney disease, Murray's surgery, even though it was a great success, it meant very little. However, all the while, work continued on more immunosuppressive medications and how to deploy them. And Murray's surgery did prove one thing, that the surgical aspects of kidney transplantation could be overcome. Unfortunately, other organs would prove to be a little bit more difficult. This is the paper that describes the first lung transplant by Dr. James Hardy at the University of Mississippi. And if you think that it was challenging to transplant a kidney, think about the challenges that are involved in transplanting a lung. In fact, the authors of this paper enumerate some of those challenges in such an impossibly droll manner that I hope you'll bear with me as I read you just the first three sentences. Transplantation of the lung presents special problems. First, it is an intrathoracic organ and one involved in respiration. Second, a degree of neuromuscular activity is essential to adequate respiratory function, without which life ceases abruptly. These were indeed significant problems. And when I say that this transplant was a success, I mean it was technically a success. The patient died within a week or two, actually, of renal failure, and it would be years before a lung transplant patient survived more than a month or two. But the heart was the biggest challenge and the biggest prize of all the organs. How would it be possible to transplant a human heart? And by the 1960s, a number of surgeons were engaged in a literal race to be the first surgeon to successfully transplant a human heart. On the left is Dr. Norman Shumway, who perfected much of the surgical technique in his laboratory in animals in the early 1960s. On the right is his former residency classmate, Dr. Christian Barnard, and their race to be the first to transplant a human heart is chronicled in the book Every Second Counts by Donald McRae. It's a good read, and I would recommend it once you get to a point in your life when you can read something other than first aid. And before we move on, I'd like to make an aside. You may have noticed that the slides to this point have been all filled with pictures of old white guys. And I'm telling you this story about incredible human accomplishments. And so I think that it's worthwhile that we all pause and reflect for a moment upon just how much farther and how much faster we could have progressed had we lived in a world where women and minority groups were not deliberately excluded from the practice of medicine. It was ultimately Dr. Bernard who became the first surgeon to successfully transplant a human heart in December of 1967. He had one significant advantage over Dr. Shumway and the other American surgeons in that he practiced in South Africa, where the concept of brain death was recognized. And so the first donor for the heart transplant was an individual who had sustained a head injury and was declared brain dead, but their heart was still beating. On the other hand, in the United States, death could only be declared after cardiac death, which meant that the heart could be transplanted, but then the heart would have to be restarted, and it made things much more challenging. And so it came to pass that by the end of the 1960s, we had successfully transplanted hearts, lungs, and kidneys. It could be done. But outcomes were still not very good. One quote from Dr. Barnard, I think, is telling. For a dying person, a transplant is not a difficult decision. If a lion chases you to a river filled with crocodiles, you will leap into the water, convinced you have a chance to swim to the other side. But you would never accept such odds if there were no lion. Even though transplants were an option, it was not an option that anyone would choose in anything other than a desperate situation. The circumstances at the time were well summarized in this paper from Transplant Proceedings in 1973. It was written by a physician who had developed end-stage renal disease and had been on dialysis, and he calls the paper, "Why I Have Not Had a Kidney Transplant After 9.5 years as a Hemodialysis Patient." And it's almost inconceivable that these days that an otherwise healthy and high-functioning dialysis patient would not want a transplant, that they would choose to be hooked up to a machine day after day for the rest of their life instead of getting a transplant. It's almost inconceivable to think about that would be a viable choice as recently as the 1970s. But yet here's a paper from a physician who had appraised the evidence and found it to be wanting. His life was going to be better without a transplant. And many other people felt the same way. And there really weren't a lot of transplants being done. Here are some numbers of cardiac transplants, and this graph doesn't even go back before 1982 because there were so few heart transplants, fewer than 100 a year that were being attempted. But something very important happened in 1983, something so important that we're going to come back to it and discuss it deliberately in a few slides. But first, we have something else to discuss. Part two, surgery. Here I'm going to begin with a little personal confession. As much respect as I have for surgeons and the institution of surgery, and that respect is considerable, don't get me wrong, I have always had very, very little desire to be personally engaged in any of it. In fact, when I was a third year medical student, the OR was probably my least favorite place to be. I found it tedious and tiresome, and after a few minutes, I was ready to move on to the next thing with very few exceptions. The most notable of those exceptions was an organ procurement surgery. It's a day I still remember even now, years later. As a medical student, to see a team of surgeons work so efficiently and quickly to remove organ after organ, and from a medical student standpoint, to peer over the operative field and see an empty thorax and an abdominal viscera that's being depleted of organs, it really was an astonishing sight. It would have been eerie except for the fact that you knew that those organs were going to be put to good use. And it was a heavy moment too, which I think is captured by this picture that I'm showing you here that shows the operative team from an OR in China saying a prayer as they've just wrapped up the surgery for an organ donor. It's not always the case that all organs that could be transplanted will be procured from a given donor. After all, something had to happen for that donor to pass away, and that sometimes leaves some organs in better shape than others. But in cases where all organs are going to be donated, the organ procurement sequence proceeds typically this way, where the heart and lungs are the first organs to be removed, followed by the liver, small bowel, pancreas, and kidneys. This is because these organs have varying tolerance of ischemia. A heart or a lung must be transplanted within 4 to 6 hours of its removal from the donor. A liver may be able to go 8 or 12 hours, pancreas 12 to 18, and a kidney can last potentially up to 24 or 36 hours. Preventing ischemia of the remaining organs is one of the key things that the surgery team and anesthesiologists have to focus on when they're doing the surgery. And let me tell you, it gets a heck of a lot harder once the heart and lungs are removed. At that point, typically what has to occur is that the remaining organs are perfused with a cold solution to keep them from experiencing warm ischemia. One typical such solution is this SPS1, or the University of Wisconsin solution as it's sometimes known. This is a schematic demonstrating how this can occur. It's an old illustration from Dr. Thomas Starzl, who's one of the pioneers in liver transplantation. And you'll notice in this picture, there's a clamp on the thoracic aorta. The abdominal viscera are instead hooked up to this heart-lung machine, which has a heat exchanger to keep them nice and cool and prevent warm ischemia. Of the three types of transplants that we're discussing in this lecture, kidney transplantation is the least technically demanding. This is still a task that is best left to the experts, don't get me wrong. But this schematic shows the basic premise. This again is an illustration from Dr. Thomas Starzl. You'll notice that the kidney to be transplanted does not go where the native kidneys go. And unless there's an indication to take the native kidneys out, which in many cases there's not, the native kidneys remain in place. Instead, the transplant kidney gets anastomosed to the hypogastric or internal iliac artery here. The ureter gets sewn into the bladder in this configuration, and the transplant should begin working promptly. The illustration that I'm showing you here came out in a journal article in 1964, but this is the same technique that surgeons use today for almost all kidney transplants. This procedure can be done without violating the peritoneum, but in some smaller kidney transplant recipients, the kidney needs to be placed intraperitoneally to give access to a larger caliber vessel to perfuse a big adult kidney. Here's the typical surgical procedure for a lung transplant. And let me tell you, these pictures, they make it look so easy. All you got to do is position the patient and spread the ribs. And then, all we got to do is connect all this stuff. So we make a bronchial anastomosis and we connect the pulmonary artery and we take those pulmonary veins and connect them to the atrium and we are done. Of course, all of this is a lot more technically demanding than these little illustrations would indicate. In particular, this step, the bronchial anastomosis. This was the weak point of a lung transplant procedure that took years to overcome. In fact, all of the early lung transplant patients, if they weren't killed by something else, they all suffered dehiscence of the bronchial anastomosis within the first 2 weeks or so of transplant. In fact, there was exactly one patient who managed to avoid this complication, and this is the patient that was pictured here. He was a 23-year-old young man who worked as a sandblaster and at that tender young age had developed near end-stage lung disease before a surgeon named Fritz de Raam performed a lung transplant. And highlights of this are available in the video that's hyperlinked here. And I know that watching a 9-minute video can be a big ask in our short attention span, time-pressured lives. But this is so good that I'm going to tease it with a couple of slides here because, as I said, I'm not somebody who really likes a whole lot of surgery, and I found this fascinating. You can see the removal of his native lung, and then this is what it looks like when the new lung is placed in. It's just a month after the transplant. He's back to, looks like weaving some baskets. And that chest x-ray, the chest x-ray just blows my mind. You can see it's obvious which lung is providing support for his life. Unfortunately, the immunosuppression available at the time was still very heavy-handed and non-targeted. And after 10 months, Mr. Varikan, the patient pictured here, died of overwhelming sepsis and pneumonia. This is the classic approach to cardiac transplantation. This picture that you're looking at came from an old New England Journal of Medicine article. And what you'll notice is that the recipient's anatomy is highlighted here in blue. The donor anatomy is highlighted in pink. And you'll notice that the recipient's native left and right atrium in the classic procedure stays in place. This approach creates at least one problem, though. Because the sinoatrial node resides high up in the right atrium, you have a suture line that runs between the SA node and the ventricle. For this reason, that many surgeons these days prefer this so-called bicaval technique, which you can see results in more of the donor heart and associated anatomy going in and preserves the donor's right atrium and the anatomy and function of the SA node. And with that, we come to the conclusion of this chapter on surgery, which means it's time for part 3, medicine. The image on this slide, of course, should need no introduction for any of us. I'm sure you all immediately realized this was Tolopocladium inflatum, an ascomycete fungus that, when it's not spending its time parasitizing certain species of beetle, is living as a mold down deep in the soil. Tolopocladium inflatum was first isolated from a specimen of soil that someone dug up in Norway and took to the Sandoz Pharmaceutical Company. Sandoz at the time had realized that many of these fungi spend their lives in a constant state of chemical warfare against other microorganisms down in the soil. And in fact, a number of very useful medicines, antimicrobials in particular, have been isolated from these fungi. And in working on some of the isolates from this particular fungus, Sandoz realized that they had a compound that selectively inhibited lymphocyte activation. They called it cyclosporin. And it was the development of cyclosporin, more than any other single achievement, that has pushed transplantation into being a viable therapy that's helped so many patients. Because it's only through the development of selective immunomodulatory medicines like cyclosporin that we've been able to overcome the single biggest barrier to successful transplantation, which is our own immune system's natural resistance to accepting a transplant. Rejection has always been the biggest barrier to successful transplantation, just like we talked about at the beginning of this presentation. Which, by the way, if you stuck with me this long, thank you. And I realize that much of the information that I've shared with you is decidedly not high yield for USMLE Step 1. But these next few slides, they will be, because we're going to talk about rejection before we return to the story of cyclosporin. This is what Dr. Volanoy was up against: hyperacute rejection. Hyperacute rejection is so called because it begins within minutes, and it occurs because of the presence of pre-formed antibody, such as to ABO blood group antigens. It is therefore, and this is a matter of great importance for the USMLE Step 1 exam, a good example of a type 2 hypersensitivity reaction. And basically what happens is that those preformed antibodies, they bind to the endothelium in the new donor organ and they cause inflammation and they form these little fibrin blood clots, as you can see in this picture here, where we have a tiny artery that is nearly occluded by a fibrin thrombus. Here you can see what that process looks like for the glomerulus, and it ain't good. Basically, the whole glomerulus in this picture is taken over by fibrinoid necrosis. If we zoom out, we can see what hyperacute rejection looks like on this cut section of a kidney. And again, it's not pretty. Look at all this hemorrhage along the cortex where all these healthy glomeruli used to live. And this is what hyperacute rejection looks like on the most macroscopic level. This kidney looks frankly necrotic after being in place for only a matter of hours. Now, this picture was a little bit hard for me to find. It came from a journal article in 2016. And the reason it was hard to find a picture like this is because this type of outcome is thankfully extremely rare in modern times. The person in this case was a chronic kidney disease patient who had had several blood transfusions and seemingly in that process had gotten sensitized to some HLA antigens. But remarkably, he had a false negative cross-match, resulting in this catastrophic outcome that you observe here. And even though it's vanishingly rare, there are some relatively recent cases of hyperacute rejection that are deserving of mention because of the consequences that they've had on our transplant system as a whole. In this picture, in the hospital bed, is a 17-year-old girl named Jessica Santillan. And back in the year that I applied to medical school, she made national news after she received a heart-lung transplant at a prestigious American academic medical center. Within minutes of the procedure, it was obvious that something had gone horrendously wrong, and it didn't take too much looking around to figure out exactly what it was. She had received organs that were not blood type compatible. Unfortunately, at that point, there was nothing that could be done. And despite all the heroic efforts that were made, including a second heart-lung transplant a few days later, she ended up passing away. Naturally, in the wake of this tragedy, the question on everyone's mind was, how? How could this have happened? How could this have happened? And I think that it's a reminder yet again that even the smartest physician is a human being, and human beings make mistakes. And it's not so much a call to be humble as it is a call to improve our systems. And fortunately, in the wake of this tragedy, that's exactly what was done. And nowadays, there are multiple double checks in place to ensure that an outcome like this could never happen again in the United States. Moving on. This is probably the most common type of rejection that we see nowadays, an acute T-cell mediated rejection. And unlike a hyperacute rejection, this type of rejection takes a while to occur. It typically would not occur before several weeks post-transplant. However, it can occur thereafter at any point post-transplant, particularly if there's a lapse in immunosuppression, which can occur with poor medication adherence. Now, for sake of example, I'm showing you what this looks like in a section of kidney. And even at this sort of gross level, we can see that something's not right here. You see lots of little blue cells. There's this lymphocytic infiltrate, and in particular, there's some foci of tubulitis that you can see, for example, over here. As a side note, this picture was taken from the American Journal of Kidney Diseases Atlas of Renal Pathology. It's a great resource, and I have it hyperlinked here and on one of the coming slides. If you're looking for extra slides to practice on, this is a great place to find them. Typically, an acute T-cell mediated rejection can be managed medically by increasing the dose of steroids or, in a severe case, giving a medicine like antithymocyte globulin. What can be a much more challenging and insidious thing to manage, though, is antibody-mediated rejection. On this slide, I have a figure from a New England Journal of Medical article, which is also hyperlinked. And I like this because it shows you the different tissue sections that you might see in kidney, heart, or lung when there is antibody-mediated rejection. I will not make you listen to me read the voluminous text that is included on this slide. I will leave you to your own devices so far as that goes. But I will highlight one important feature of antibody-mediated rejection that, at least the last time that I looked, is curiously omitted from first aid for the USMLE. And that is the significance of complement C4D. Shown here is a section of a kidney biopsy, and it's stained with an immunofluorescent stain for complement C4D. you'll notice that the pattern in which the stain lights up is the vascular portion of the kidney. This is a key point because C4D is the cardinal feature of antibody-mediated rejection. And the reason why is depicted here in this cartoon from Jason in 2002. As a side note, this is not new information, so I'm not sure why first aid includes things like OKT3 that you're never going to use in transplant medicine, but does not include C4D. But I digress. The point here is that in the presence of donor-specific antibodies, the antibodies will bind to the surface of the vascular endothelium and then fix complement. And so when this C4 attaches itself to the cell surface, it then later gets cleaved and leaves C4D in its place. That means that where C4D is found in a biopsy, we know that earlier there was a donor-specific antibody in that position. Antibody-mediated rejection is a much more challenging entity to deal with clinically than a cellular rejection. And that's because our immune system is good at making antibodies. And once it starts making antibodies, it's tough to get it to stop. So therapy for acute antibody-mediated rejection typically involves plasmapheresis, a therapy to remove the antibody, and then increasing immunosuppression to try to target the cells that are producing antibodies. However, once this process begins, often it is impossible to get it to stop. Let's move on to one of my favorite graphs in the whole talk. What I'm showing you here is the percentage of kidney transplant recipients who have experienced acute rejection within the first 12 months of transplant, and that's this red curve here. And you can see that as time goes by, that percentage has steadily decreased. On the other hand, the blue curve reflects the percentage of transplant recipients who have been able to keep their graft for at least 1 year. So note that in the early days of transplant in the 1960s, the 1 year graft survival rate was only 40%. Your odds weren't even 50-50 that a year later you would have that kidney transplant. And of course, that's related to the crummy immunosuppression that we had at the time. Basically, to try to keep your kidney working, we would use old school medicines like 6-mercaptopurine and huge doses of prednisone and even focal radiotherapy. By the time the 1970s came along, we had an important addition. We had azathioprine, an anti-metabolite medicine that made this a much better therapy. And you can see here, through the azathioprine era, we had about a 60% 1 year graft survival rate. But the big quantum leap forward did not occur until 1983 with the introduction of cyclosporin. I promised I was coming back to that. But notice how these curves deflect in the years after cyclosporin was introduced. Suddenly, with cyclosporin, 80% of kidney transplant recipients at least got a year out of that kidney transplant, and that fraction has continued to improve as more centers adopted cyclosporin and perfected their use of that medication. But these days, most kidney transplant patients don't take cyclosporin. They take tacrolimus, a different calcineurin inhibitor. And you can see that from the time that tacrolimus was introduced, although the 1 year graft survival didn't really change much, the percentage of patients who experienced rejection dropped steeply. And that was followed up by the introduction of mycophenolate, which replaced azathioprine as the anti-metabolite in many transplant protocols, as well as antibody induction. Here's a slide that summarizes the basic current armamentarium of transplant immunosuppression. And listen, this is a rapidly evolving area, and already there are many centers who use different protocols, but this gives you a basic idea about what patients receive. The general principle is that when a patient receives an organ transplant, you need to use broad-based and heavy-handed immunosuppression initially. But if that's successful, a patient will develop a degree of immune tolerance of the graft that still requires immunosuppression that's ongoing and targets multiple specific targets in the immune system. What this looks like clinically is that a typical transplant patient will receive an antibody induction therapy, such as ATG, antithymocyte globulin, or basiliximab. And then that's followed by maintenance suppression with a calcineurin inhibitor, such as cyclosporin or tacrolimus, as well as an antimetabolite, such as azathioprine or MMF, and then steroids. So a 3-drug maintenance immunosuppressive regimen. Again, I know you don't want to hear my voice reading to you all the tedious text on this slide, and so I'm going to leave that to you. along with the observation that the mechanisms of these medications, as well as some of the toxicities, are probably the most high yield material from this lecture aside from the mechanisms of rejection. You may also find this figure helpful if you're looking for a yieldy sort of review of immunosuppressive medications. Instead, I'm going to get back to the clinical management of transplant patients, which really comes down to this: the precarious balance between rejection and opportunistic infection. When we look back at that slide that I showed you before about the early immunosuppressive regimens, and we see things like that focal radiation and the high doses of steroids, and to us these days, that just seems so impossibly crude. And I think that future physicians are going to look back at our era right now in much the same way, because it is extremely difficult to put patients on enough immunosuppression that you prevent rejection without increasing the risk of infection. Transplant recipients are at risk for a number of opportunistic infections, and the list that I present here, even though it looks long, is by no means exhaustive. It's important to remember when you're confronted with a USMLE vignette or a patient in real life who is taking immunosuppressive medicines, you've got to remember to keep a broader differential for some of these microorganisms. Since this is the kidney module, I will highlight only one in particular for this talk, and that's BK nephropathy. The BK virus is a polyomavirus. The initials BK stand for Barbara King, who is the patient from which this was first identified. But it's a virus that's ubiquitous in the world. Most of us have it. It established itself in the renal tubular epithelium or uroepithelial cells, but in the context of immunosuppression, it can become activated and begin to replicate and cause damage to the allograft. One of the key findings of BK nephropathy is shown on this slide, and that is these inclusion bodies inside renal tubular epithelial cells. You can see similar things in CMV infection as well. Moving on, what I'm showing you here is the median half-life for an adult kidney transplant. There are two curves on the graph. The blue applies to living donors, the red applies to recipients of deceased donor kidney transplants. There are two things to notice about this. One is that outcomes are generally a little bit better with a living donor kidney transplant than with a deceased donor transplant. But the more important thing to observe about this is that a kidney transplant doesn't last forever. That brings me to one of the key points for this talk, and that's this. Transplant is a treatment. It's not a cure. And it's something that all physicians and transplant recipients should understand. As magical as transplant can seem sometimes, a patient who receives a transplant is really trading in one chronic illness for another. And fortunately, in almost all cases, that disease that they're trading is much more difficult to manage than a transplant. But the transplant is not a cure. What this means is that the decision about whether or not to pursue a transplant for an individual patient is often an area where there needs to be some shared decision making and some judgment on the part of the medical team. Ultimately, the decision about whether a patient is a transplant candidate or not hinges on the answer to this question: would the patient benefit from having a transplant? And that question usually has two prongs that go into the answer. The first prong is medically. Medically, would the patient benefit from receiving a transplant? And in some cases, regrettably, the answer is no. A patient with active malignancy or other serious health conditions, a transplant is not going to make their life better. The second prong imposes a question that can be a little bit uncomfortable to answer, and that is, does the patient have the ability to manage a chronic illness like a transplant? It's uncomfortable because in many areas of medicine, we don't have to do that. I mean, even if you have a poor social situation or a history of poor adherence, we'll still prescribe insulin or antihypertensive medication because it's the right thing to do. And if you take it, you'll benefit, and if you don't, you won't benefit as much, but we still give you that therapy. In transplant, that's not really possible because we live in a world where we have a huge number of people who theoretically could benefit from a transplant and a very limited supply of available organs. And any transplant that we give to someone who is not set up for success, by necessity, takes a transplant away from somebody who might have done better with that organ. Medication non-adherence, therefore, becomes an absolute contraindication to offering transplant. If a patient, for whatever reason, is not able to obtain or reliably take immunosuppressive medicines, their transplant's not going to make their life better, and it's going to make someone else's life worse. This is a nice segue into part four of our discussion, policy. It's because we do not have enough organs to offer to patients who might theoretically benefit from transplant that makes transplant medicine one of the most heavily regulated from a policy standpoint areas of all of medical practice. And it leads to thorny problems, which we'll sort of skim the surface of. But first, let me provide a basic overview of the transplant landscape. This is the number of transplants that were conducted in 2019. These data come from the United Network for Organ Sharing, or UNOS. As you can see, in 2019, there were over 23,000 kidney transplants done, which is more than all the other transplant types combined. There are really two reasons for that. Number one goes back to part two of this talk when we were discussing the surgical technique. The kidney is a little bit more resilient organ than a heart or a lung or a liver. And there are some cases where the nature of the donor's death has ruled out those organs for transplant, but the kidneys might still be viable. The second reason, though, and the more important reason, is that about half of the kidney donations that were done came from living donors because almost all of us are born with two kidneys. And it means you have a spare. You can live a healthy life with just a single kidney, which means that you have one available to donate. And that's not an option for a heart or a lung transplant, for instance. Actually, for the past decade or so, there's been a way for you to donate a kidney to help one of your loved ones, even if you are not a match for your loved one. This is called paired donation, and this graphic here explains how it works. The particular example comes from the University of North Carolina, and if you're interested in reading their article about it, I have it hyperlinked below. Essentially, they had two patients, one who needed a kidney transplant, that's Chelsea, and one who was willing to donate a kidney, and that's Wanda. But unfortunately, Wanda was not a blood type match for Chelsea. However, because there is now a national registry of situations like this, it may be possible that Wanda could donate to someone else, and that person's donor, who's not a match for them, could donate to a different person altogether, and that person's donor, who again was not a match for them, could donate to a different person until the chain eventually closes. The longest chain of kidney transplants happened several years ago, and it involved 60 donors and recipients at hospitals all around the country. Running chains like this is cumbersome, but it's worth doing, and it's an ingenious solution to the problem of limited organ availability. Because many people who do have a living donor who might want to donate to them, they don't want to just donate to anybody if it doesn't benefit their loved one. And systems like this are a way of increasing the available organs so that these people are not waiting on the deceased donor list with everyone else when they have a potential living donor available. This graphic shows organ procurement organizations in the United States, or OPOs. OPOs are the organizations that actually coordinate all of the nuts and bolts between donor and recipients and the hospitals where those people may be. You can see that instead of having one giant national body who does all of this, it's configured locally with borders that roughly geographically correspond to state lines, but not always. If you look closely at the Virginia map, for instance, you'll see that most of Virginia is served by an organ procurement organization called LifeNet Health. You may have driven by their offices out in Virginia Beach. But you'll see there's some counties in Virginia that are served by the organization that serves most of North Carolina, or the organization that serves most of Tennessee, or even the organization that serves the District of Columbia. Configuring things geographically within local networks is a pretty logical thing to do, given that organs have a very limited shelf life. You can't be taking a heart or a lung from one state and flying it across the country, because by the time it gets there, it's no longer going to be of value to the person who you intended to give it to. So organs are offered first within their organ procurement organization. However, this leads to some disparities in transplant medicine, because the rate at which people choose to be organ donors varies significantly by states. In some states, such as Washington State or Alaska, where people have to opt out of being an organ donor, over 90% of adults are registered to be organ donors. On the other hand, in some states like New York, only about 30% of people are organ donors. What that means is that the supply of available organs in a state like New York is much less relative to the population than in some other states where more people sign up to be donors. That means that the waiting time may be 5 times as long in some states compared to others. So what should be done about that? Well, a couple of years ago, for example, UNOS made a policy that liver transplants would be allocated to the sickest recipients who lived within 500 miles of the transplant donor's hospital. That would bypass these boundaries imposed by the OPOs. Seems like a good idea, right? I mean, that way we can allocate livers more efficiently. Of course, after this policy, UNOS promptly got sued by academic medical centers in Michigan and Georgia and other states because, from their standpoint, why should their patients be disadvantaged when they live in states that have higher rates of organ donation? Why should their patients die on the waiting list while their organs that could have benefited them get flown off to Philadelphia or New York? It's a tough question, and it gets back to the thing that I mentioned earlier that so long as we have a limited supply of organs, anything that we do that advantages one patient by necessity is going to disadvantage another. And we have to make those decisions very carefully. This is a slide from UNOS, and it shows basically how the transplant waiting lists work for various organs. If you look at kidney, for example, kidney is the only organ where waiting time is the top most important factor. And that's because for patients awaiting kidney transplant, we can support them chronically with dialysis in a way that someone who has lung failure or end-stage liver failure or end-stage heart failure, we simply can't support those patients to the same extent. And so allocating by wait time isn't a good policy for those organs. In comparison, liver and heart transplants are allocated primarily by medical urgency. You have to be kind of on death's door to have a realistic chance of getting a heart or liver transplant. You may be listed for a while, but unless you're very, very, very ill, you're not going to reach the top of the list. And that's because patients simply can't wait. Lung transplants, interestingly, you'll see that the top factor is survival benefit. And this is because of the complexities involved with lung transplantation. It's a challenging procedure, and you have to be very, very sick in order to benefit from it. But you also can't be too sick because then the transplant won't do well and the organ will be lost. The way they try to do that is by calculating something called the lung allocation, and this is what it looks like. Here are all the variables that go into the equation, and it spits out a number between 1 and 100 that provides what your priority for transplant should be. And it's based upon your likelihood of survival. And so unfortunately, it means that some patients who have end-stage lung disease are not candidates for transplant. If you have certain infections, if you have chronic liver disease, if you have chronic kidney disease, you're not going to be a candidate for lung transplant because those comorbidities mean that your likelihood of survival is too low for it to be a justifiable treatment for you when there's someone else who would likely survive longer with the same organ. It's a tough thing, I think, to explain this type of decision making to a patient, to say you're so sick that a transplant is your only hope, but also now you're too sick to even be a candidate for that therapy. And yet, this is the kind of decision making that we're forced to do. This is the kind of thorny policy decision that I was alluding to before when we're talking about organ allocation, because anything that we do necessarily benefits one person at the expense of another. Here's a good example for kidney transplant. Pediatric status gets you extra points. As a pediatric nephrologist, I love that policy. Kids do very, very well with a kidney transplant. And on the other hand, they struggle on dialysis. Um, so to me, it makes perfect sense that we should allocate kidneys preferentially to kids. And obviously, UNOS thinks so too. There's a group of people, however, who feel otherwise. And they point to data that show that since this policy went into effect, the same number of children ultimately get transplanted, i.e., this doesn't prevent children from dying before they get a transplant. Instead, what happens is that some children seem to be getting transplanted with deceased donor organs rather than living donor organs. Meaning, before we had this extra allocation priority, maybe pediatric nephrologists did a better job of hounding families to go out there and beat the bush and find altruistic donors and come up with someone so that your child doesn't die while they're on dialysis. Maybe we did a better job of that now. Maybe it's too easy for us to just say, oh, you don't have a donor? All right, well, we'll just put you on the deceased donor list. But any child who potentially had a living donor who then takes an organ off of the deceased donor list, they're taking a kidney from someone else's patient. Someone else is going to die on dialysis. That's the hard realities of living in a world where we have more people who need transplants than can possibly receive them. Naturally, given the complexity of the issue, there's a counter argument to that counter argument. And that is that, if you're a pediatric recipient, you just don't want any old person's kidney. I mean, maybe a family could come up with some marginal living donor, someone, a great aunt who's, 60 years old and has had diabetes and she's willing to donate a kidney anyhow. Maybe that's not the best kidney to give to a young recipient, given that we know that that person, if they live the kind of life that we want them to live, they're going to be back needing another kidney in 10, 15, 20 years. So maybe that's not the best decision for society to use a marginal kidney for someone who has a greater life expectancy. And indeed, that's something that's also now built in to the UNOS allocation for kidneys. There's something called the Kidney Donor Profile Index, and it's a measure of how likely a given donor's kidney is going to provide years and years of function. As you might expect, some donor kidneys provide a greater likelihood of working for a long time than others. We get a disproportionate number of organ donors who are young, otherwise healthy men who die from some type of unfortunate head trauma or substance abuse. And they're always tragic situations, but the kidneys often work quite well. They work better, for example, than a kidney might from a 55-year-old with a history of hypertension. That kidney's going to have a little bit more mileage on it. So the KDPI formula takes that into account and preferentially allocates kidneys with a lower KDPI to pediatric recipients and recipients who are expected to need a kidney for a longer time. That doesn't mean that a high KDPI kidney is a bad kidney. There's someone for whom that may be very beneficial. It may be an older person who spent a lot of time on dialysis. Their life may be made dramatically better by receiving that transplant. Even if it only lasts for 5 or 6 years, that may be all that they need. But for a 2-year-old who's receiving a kidney transplant, we don't want a kidney that's going to be used up in 5 years. We want something that's going to last as long as possible. The point of all these kind of formula and calculations is how can we do the most good for the greatest number of people with the limited supply of organs that we have? And I hope that thinking about this leads you to one other conclusion, and that is that the best solution in the present time would be to increase the supply of donor organs that are available. And so I have a specific request so far as that goes. In Virginia, you have to opt in to being an organ donor. You have to check a box when you renew your Virginia driver's license. And so I would say if you're listening to this talk and you haven't done that, please think about doing it. If it's not possible to increase the supply of donor organs to meet the demand from patients who would benefit from receiving a transplant, then it's possible that the future will hold better options for transplant patients. And so that brings me to part 5, the future. And I'm going to be very brief here, but what I want to do is highlight a few ways that we might get out of this situation where we have too many people who need transplants and not enough organs for them. The first way, of course, is just to provide better therapies for the primary diseases that lead to organ failure. If we manage chronic kidney disease better, you'll have fewer people who end up needing a transplant, and the same is true for heart and lung diseases as well. A second possibility would be to use bioartificial organs. And indeed, for hearts, we're kind of there. I mean, you will see patients with left ventricular assist devices, and some patients will receive this as destination therapy. Some will receive it as a bridge to transplant. And as that technology continues to improve, it may eliminate the need for so many people needing an actual kidney transplant. Another possibility would be that we have better tailored immunosuppression. I think that's one of the themes of this talk is that it was only through the development of selective immunosuppression that we've been able to offer transplant as a viable option to patients. The final way, which still seems the most speculative at this point, is that we could find ways to induce tissues to heal. Right now, when you're born, you have all the nephrons that you're ever going to have for the rest of your life. And once they've been depleted, there's no way of making them grow back. But what if there was? And in laboratory studies, it seems like there may be some signals that can be provided to do just that very thing. And with that, we come to the end of the lecture. I'm going to close with a picture that I took on my way into work at CHKD on a bright September morning not long ago. It's the CHKD Butterfly Garden, and it's a place that you've probably passed by, or if you haven't, I'm sure you soon will. And when you do, I hope you pause and take a moment to reflect on some of the symbols that are in this place. The bronze butterflies that adorn the walls all have the name of a child who passed away and donated their organs to someone else. The butterflies were chosen to represent metamorphosis and remind us that in some cases, when one life ends, another gets a chance to continue on. Transplants aren't magic, but I think that there is a little bit of magic in each one of these human stories. And I hope I've been able to convey a little bit of that to you today, along with some of the scientific foundations of transplantation medicine. Thanks again for your attention.